Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Psychologists in Pediatric Settings, Psychosocial Support for Children Diagnosed with Differences of Sex Development and Their Caregivers, presented by Dr. Georgette Richardson. This is the second session in the two-part webinar series on differences of sex development. My name is Kathy Dixon, and I'll be moderating the session today. I'll cover just a few housekeeping items before we get started. Following the presentation, we'll have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many as time allows. The webinar will be recorded, and I will share the link in the follow-up email after the session. Instructions for how to claim credit will be uploaded to the chat section, and I will also send this in the follow-up email after the webinar. So without further delay, it's my pleasure to introduce our presenter today. Dr. Georgette Richardson is a clinical assistant professor in the Stead Family Department of Pediatrics, Carver College of Medicine, and pediatric psychologist at the University of Iowa Stead Family Children's Hospital. As a pediatric psychologist, she specializes in working with patients, children, adolescents, and young adults who are diagnosed with acute and chronic medical conditions, as well as their parents or caregivers. Dr. Richardson uses evidence-based interventions to address the unique challenges of frequent medical appointments, medication regimen, adjustments to a new diagnosis, anxiety related to medical procedures, and the impact of chronic health on daily activities and relationships. So welcome, Dr. Richardson. I'll turn it over to you.
Thank you, Coffee. I appreciate that wonderful introduction. And thank you, everyone, for joining us today. Okay, we'll do the click. So yes, this is the second part of our two-part webinar series, and we'll talk about patient and family-centered communication that's sensitive and respectful. I'll provide some examples of psychosocial support for helping children and their caregivers following a differences in sex development diagnosis. And then how to encourage children to be active participants in their own healthcare will be discussed today. There are no conflicts that I need to disclose. As a psychologist in a pediatric medical setting, I conduct assessments and I look at the whole person, the development, emotional, behavioral, social, and family aspects that interact with the physical diagnosis, and help provide interventions, psychological interventions, to help with the effective adaptation. I also help support caregivers. The parents play a very important role once someone has received a diagnosis. And so I provide a therapeutic environment to help process the emotional response following their child's diagnosis. I promote confidence and their ability to communicate to their child and answer some very uncomfortable and difficult questions, as well as help provide strategies to help regulate their own emotions as they begin to advocate with medical providers or nursing team members. But most of all, I help identify and promote resiliency factors. So identifying key people in those family social networks who can offer emotional support or practical support, and encouraging that resilience by leveraging those connections. I kind of talk about the foundation of how I create a therapeutic environment are using the principles of patient and family-centered care by becoming an active listener. I want to help create an environment where we have a therapeutic alliance and to better enhance treatment adherence and health outcomes. So I work on allowing the space for the family or the child to share their story. I use open-ended questions, wanting to hear what their perspectives are, what it felt like when they received this very difficult and unexpected news. Um, I want to hear about what emotions impacted them or what things they felt, and acting sensitively as well as non-judgmentally in this setting first, to help provide a really well-supported alliance so that we can continue to do some really hard and challenging things together. So in active listening, the first step is that I do a very thorough medical chart review. Um, Patients and families that, are affected by DSD diagnoses might have had a long road before meeting with me. And so being able to understand their trajectory gives me some preparatory knowledge, um, and helps my listening ear, um, especially when we start giving introductions. And I pay attention to the name that folks are using. I listen to how they refer to themselves, and their role as well. In conversation throughout our session, I use phrases like your baby and your child. And through getting to know the whole person, I make more descriptive comments, or I talk about qualities that I see and observe outside of the DSD diagnosis. Um, Always during, especially initially following a diagnosis, speaking factually is so critical and important, to help enhance more knowledge and understanding about the diagnosis. For instance, I use a person's diagnosis, I use facts about sex chromosomes that don't match the appearance of genitals, which can be discovered before birth or after life or later in life. And I might also use the phrase child not going through puberty or menstruation not starting. And I really bring up that these diagnoses affect people from infancy through adulthood. Um, Things might be discovered before birth, soon after birth. They might be discovered during puberty or throughout adulthood. And they can also affect someone's outside of the body as well as their inside. I wanted to also emphasize, which our first part of our webinar series really provided an understanding that patient-centered language, avoiding outdated and stigmatizing terminology is so important and critical, especially at the first notification or when first someone is learning about their new diagnosis. Because it's very common to hear words or phrases that has the person feeling ashamed. Following the patient's or parent caregiver's lead about words, descriptors that are used, and demonstrating respect with shared decision making, letting everyone know about the different options, the patient, the child, as well as their caregiver, and letting them know the different options and what those options might lead to really helps demonstrating respect and allowing them to be part of that decision making. As we're starting to learn about the whole person, I definitely make sure that I talk about different characteristics that I see, to promote attachment and bonding. I like to describe things that I see in the interactions between a parent and a child. Um, how would you describe your child's temperament and what calms your baby? Um, this really helps allow a parent, a caregiver, to understand how well they parent and to see that their child is responding to them in an appropriate way when they might not feel as effective as they wish they could be. I talk about what a child is learning and growing. So, what are you learning in second grade? What activities do you enjoy doing, such as what's a favorite movie or a superhero that you have? To bring the language and the conversation that we're having outside of the diagnosis and trying to enhance getting to know them as a whole person. I wanted to provide an example of how I've done that in the past. I was referred to work with Sally and her mother for the first time after they received her new diagnosis. And Sally was a very energetic child. Her eyes would light up when describing her plushie toys. And Sally's mother was very attentive to her and her needs. What I was consulted to promote psychological adjustment following their diagnosis of partial androgen insensitivity syndrome, or PAIS. And in the referral, the medical team emphasized the importance of supporting emotion regulation after learning this unexpected news. This family was very distraught. Questions about how to attend slumber parties, being a part of ballet and the uniform for attending or participating in that activity was a great concern. And so when speaking with Sally, she asked questions like, why did I have to change? And her mother had concerns about, is this because of me? Or should I have done more before now? And these questions let you see the natural worries and the uncertainties that come with a new diagnosis. It's important to address these concerns with empathy and providing reassurance to both Sally and her mother. And by validating their feelings and offering support, we can help them navigate this challenging time. Validation is what makes you feel heard and respected. As a psychologist, I support patients in the clinic by validating their feelings, which help them feel more understood. For example, I might ask, how would you describe how you're feeling? I might provide a detailed list that gives words or faces or images that might describe those different feelings. Or I might give examples of other children have said that they felt mad, confused, uncertain. And then being able to normalize the reaction to a new diagnosis, that's very crucial. After meeting with multiple medical providers, being asked very many questions about their medical histories and learning the many new things about themselves, some people I've met had lots of questions about how to live out their everyday life, how it's going to change, how to interact with friends or family members. And it's normal to feel a range of emotions in response to this news. Then validating their response by saying it makes sense after getting this news that you are feeling scared or confused. I might say other parents have felt mad and don't want to accept this news. That makes sense, and help them feel that they're not alone in this experience. In examining the research literature that is documenting the psychosocial implications of disorder or of differences of sex development treatment, there's some literature on the effect of parents of these children. And historically, studies of caregivers have been limited. We don't really know much. They haven't been included, as well as describing their role in the treatment. In the articles and the studies that have been, the studies that do exist, reveal that parents of young children with DSD experience extreme stress, anxiety, depression, and a decreased quality of life, similar to parents of children with other chronic illnesses. And these parents often exhibit overprotective parenting. They perceive their child as more vulnerable, which can hinder the child's emotional and social development over time. And parents of children with DSD may face more perceived, meaning things that they notice or feel, or actual child-focused stigma. And the article that I provided here, they talked about a need for interventions to improve parents' psychosocial functioning or their adaptation to their child's medical condition, including coaching on how to discuss the condition with their child. A common response initially for most people, including those that are parents and have their child receiving DSD diagnosis, is struggle with believing what the doctor is saying at first. Acceptance is a process, and it doesn't happen in one moment. To begin to heal from the sadness or the anger that one might feel, it's important to acknowledge the truth, including the reality of your child's situation and your own feelings. So parents might deny reality by asking themselves, how could any of this be true? How could this be happening? They might feel grief or loss by thinking, I feel like I have to say goodbye to my little girl. Embarrassment is a very common emotional experience, and it might sound like I won't ever be able to say genitalia. I might not be able to feel confident or without hesitation saying the word breasts. And additionally, parents might feel isolated and ashamed, expressing things like, I am so ashamed I can never tell anybody or tell my mother about this. Recognizing and validating these emotions are crucial in the journey towards acceptance and healing. By acknowledging these feelings, parents can begin to process and then start to move towards understanding and support of their child. In Sally's case, I supported adaptive adjustment by addressing these questions and providing guidance. That includes how to talk to their child, especially as they grow up. And so while most of us learn about cognitive development, we learn about motor development as a child grows up and language development, there's not much of an emphasis placed on a human being's sex development. That is an area that most of us don't have much knowledge. It's not readily or openly discussed. And education about sex development should start before birth. So being able to talk about while in utero, what happens to a person, covering topics like genitals before birth and how sex development works. There's some resources at the University Health Network, as well as illustrations provided by the Hospital for the Children of the Sick Children, that provide valuable information on sex development. In a multidisciplinary team, I frequently go and ask my medical colleagues for the resources to explain typical development and differences based on a child's diagnosis. Normalizing honest communication about differences is crucial. Important to always be open and ready to talk as your child is ready, whether it's sometimes or other times. That's a strategy that I use and try and teach parents to use in their phrasing, that when we have DSD diagnoses and we're explaining what occurs, Using the phrase sometimes or other times can be very helpful. Girls may have certain experiences while other girls may not, and that difference is okay. This same can also apply to boys. Over our lifetime, our bodies change. And as we grow up, it can be common that some people start puberty at one time and another might start it later. I encourage writing letters, especially to those that have infants or toddlers. In writing these letters, they're able to explain in the moment what it was like hearing the news about their child, what their experience was, talking to different medical providers. The decisions that they had to make is a crucial element to being able to identify how they came about making their decision for their child, as well as expressing uncertainty. It is also important to write, capture in these letters, or when speaking to their child about being uncertain about certain knowledge and information. Modeling, let me write that down for the next time we have a visit with the name of their provider. Or let me ask someone who knows. It's also helpful to revisit questions the child has asked previously. Privacy should be emphasized, but not treated as a secret. Common to receiving these diagnoses, parents have a lot of shame and a lot of embarrassment, and it's very natural response, a protective response for parents to want to shield their child and their medical condition from the public. And for example, going to I teach certain phrases and encourage families to talk to their medical provider, modeling for them how to talk about private body parts to their child with different language. So going to the bathroom involves closing the door for privacy. Body parts that are covered by our underwear are private. And in the family, these parts are discussed with our parents and with our doctors. And then as the child gets older, parents working with doctors can come up with finding the words to share their private information when they are ready. And as I talk about helping prepare a child to be more participatory, to start taking the lead in their own healthcare, we'll talk about different ways that people might come up with uncomfortable or uncommon questions that they might get from their friends. By working closely with both youth and their parents, psychologists ensures that a transition is smooth from child or pediatric setting to adult. There's a knowledge and understanding, there's asking questions, there's participating in treatment decision making. And what we call that is the pediatric to healthcare transition. And it really focuses on the ability of young people and young adults to manage their own health. And this might look like calling and scheduling an appointment, refilling prescriptions, or it might be as much as following a regimen without as many reminders or urges or pushes from caregivers. And how psychologists help in that is by supporting gradual movement from caregivers being overseers for their young child or for their teen, and helping them to become more of a consultant role. And this might be answering questions when asked to young adults around their healthcare, but allowing them to learn alongside with them what their experiences is like as helping them with their healthcare, and then shifting from more of a supervisor to standing and sitting beside them as they take the lead. Important topics for youth with a difference in sex development diagnosis are three areas. So questions about the gonads and understanding about doctors' monitoring of them, which means looking after them over a period of time. A second is hormones. When you don't have gonads, or if your gonads don't make enough, it means that our doctors will probably want to discuss taking hormones or helping your body go through puberty to stay healthy throughout your life. And the third area is managing your genitals. And some folks might be considering surgical options in managing, but it's also important that in making those decisions with the management, talking with someone that's a psychologist, social worker, a nurse, and peer support about making that decision and what it all might mean. I encourage using pictures in specific time frames, so 6 months, 1 year, or making it known that in the next month. Depending on the age and development, saying 1 day can be very overwhelming, but limiting the knowledge to a specific time frame is very helpful, along with encouraging curiosity and questions with pictures so that they can see. Yeah. As questions come up, teens might be wondering in session, my children might be thinking about having different fears or worries that may or may not have an answer right now. A strategy that I use are naming different buckets. And those different buckets help us know where to place those questions, those concerns, those worries, those fears to a certain area. So, for example, the buckets might be labeled psychologists. They might be labeled endocrinologists or surgery or urology or gynecology. And that's where we might put that question, comment, or concern so that when we see them next, we can talk about that openly. One bucket that we really work hard on building up and filling up is the most important bucket, which is the bucket that talks about you. I really enhance that before we start thinking about our relationship with our friends, that we first talk about the relationship with yourself. How do you see yourself? How do you understand yourself? Who you are and what makes you happy? And as we start, navigating different social relationships that one might have as they grow up, it's important to make clear, but also to have them start developing their own questions about who they are. I ask that youth start thinking about what are their family's values, what is important to them, and what values would they like to add that might be different from their family? How do they want to live their life? Explore who they want to become, understanding and actively making decisions about their puberty can really be helped with knowing who they want to be and what they want to become in the future. As they start thinking about conversations with friends or exploring who do I like? What do I like? Who am I attracted to? With who I want to become, a very important and critical role would be, what do you hear in your heart about who you are and what you want to become? This could be a parent, because there's many very beautiful ways that people can become parents. Understanding your body, especially whether you can help make a baby, is very important. We talk about puberty And whenever certain people are noticing that others are going through it, what does it have in store for you? No one person going through puberty is alike, and we want to help you understand your changes. Again, with our youth that are diagnosed with DSC diagnoses, that have these medical diagnoses, we really talk about privacy and secrecy. Some parents or even doctors encourage that individuals wait to telling other people. I want to emphasize again that the message that things are hidden, a secret, is found not to be helpful. If you choose not to tell people, we really want to emphasize being willing or being open to tell your story is when you are ready to tell your story. Sally authored a very, very compelling story about how her story belonged to her, and that it was her decision on who and when to share her story with, or share her story with someone else. And when she was uncertain about how to describe questions that might come up to her friends, opening up to her healthcare provider about, you know, how do I say I haven't gotten my periods yet? Sometimes I don't get periods could be simple enough. But if we find that they keep pushing, saying that I don't have periods, my doctor knows, and it's okay, can be a way to say, I'm talking to my doctors about it, and I'm not ready to tell my story about that. Questions about who do you like can be things about who you are is normal growing up in the world. And as these questions go up, I refer them to think about what they would like to do with their life and how they would like to interact with others. Just recently, I came across some information, but before we go there, in writing their story for young adults or from young teens, we talk about what it might be like if someone faces rejection once they share their story. That is always going to be a vulnerability and a worry. And an important element in our sessions when working with teens is how to move towards this might be someone else's reaction and it is okay, and reminding themselves of who loves them and who supports them every day in their life. I know recently there was an executive order that was issued on January 20th. And then in February, the Pediatric Endocrine Society issued a policy statement, and I wanted to provide that as a resource to everyone. I know that if individuals or they might hear from patients and families about having questions, that the Pediatric Endocrine Society can be a very valuable resource for understanding how to understand someone's health as it might relate to executive orders that have been issued. These are my references. And I just want to thank everyone for attending and over their lunch hours for getting this additional information and learning these additional skills so that they can be of service to others. As well as I just thank you for, being interested in how to support the mental health and the psychological functioning of the people that you serve. I wanted to go ahead and open it up for questions or any comments or anything like that.
Well, thank you, Dr. Richardson. for a wonderful talk. You shared a lot of wonderful information. I think that'll apply um, to providers in their clinic, the family-centered approach, um, the whole person approach, and some of the information you provided. If people want to put their questions in the Q&A, we'll get started with some questions here. And we did have a couple of questions submitted during registration, and we can start with those. One of the questions was, what are some resources that parents and patients may use for information and support?
Yes, no, this is wonderful. I know that Coffee shared that both of our webinars will be available later for reference and review. And so being able to bookmark those or have them in a place where you could refer to them in case that you would like to call up some important information or tidbits. But the Pediatric Endocrine Society, they provide helpful resources to parents and families, as well as they have a resource page as well. The number one place to go and get accurate information, I want to tell them to go back to their medical team. The medical providers will be connected with professional organizations and the most current wisdom about the child's diagnosis, as well as what type of psychosocial concerns and how to get appropriate support that might come up.
Okay, thank you. We had another question. What is a good age to start having conversations with children diagnosed with a DSD about their differences?
Yeah, I highly recommend as early as possible and using developmentally appropriate language. And so if we're talking about a 3-year-old or if we're talking about a 12-year-old, I urge that parents listen to the way that their medical provider talks to the child about their body, making things concrete, such as a heart goes boom, boom. That can be a very useful and also something that a child that's 3 years old can feel. And whenever talking about lungs or talking about urine, listening and talking to the urologist about different parts of the body, especially areas that are private and covered by our underwear, can be very helpful. And following their language and asking questions. It's okay to say, I don't know what to call this and how to talk about it when my child brings it up. Can you show us or tell us in session? That's very common. And in sessions with parents and their child, we get comfortable being uncomfortable. We get comfortable stuttering, pausing before we say it, going slowly. I could role play with a parent, and as they ask the question, they might pretend to be the parent, or I might pretend to be the parent, and we practice how to respond with shocking questions. But once we get the hang of it, and once we kind of bring up our worst fears of what could be asked, it becomes easier overall.
Okay, thank you. What do you recommend when parents and the patient are not in agreement on the direction of their care?
Yes. And if maybe they could provide some more context, like the age of a child is something that comes to mind. If the parent and a child are in disagreement, I think that it's very natural and common that, especially as an adolescent, young adult becomes into forming their own identity, or uncertainty of who and how they want to be in life, it's common that caregivers or parents might have differing opinions. One way is the first place I always start is how soon does this decision need to be made? Looking at timelines, getting the facts from the medical providers. Is this decision, how fast does it need to be made? What are the health risks of waiting 2 weeks, 4 weeks, a month to making this decision can be very helpful and the best place to start. Once we start to know more information about timeline, I noticed that the pressure and the urge and the hastiness to make this decision can slow down a little bit. It gives time for both the parent and the youth to share both of their perspectives. And listening to each one, I want to hold up, are these perspectives that have to do with their physical body, as well as their hormones, things that are on the outside or inside? And when those questions come up, ask them to take those back to their medical providers and talk about how that decision might affect the rest of their life. If it has to do with a disagreement with how someone's identity might be walking through everyday life, that might take a lot longer for the youth to gain understanding and acceptance of their parent's perspective, as well as the parent to understand the perspective of their child. And over time, we can work and talk about it because there can be relationship implications that can be quite distressing to a family unit.
Okay, thank you. Can you talk about, what are some of the common mental health concerns you see with children diagnosed with DSD?
Yes. Upon first diagnosis, um, I notice more parents feeling more distress, but as a child gets older, um, anxiety and depression, those type of symptoms, but I don't usually um, say that they rise to the level of a psychiatric diagnosis, especially if it's about their medical condition. And I say that because without a DSD diagnosis, would these symptoms be present? And so if someone is displaying uncertainty, distress, um, not feeling as if they know who they are, um, those common questions or thoughts or worries or fears are common, especially if you have a diagnosis that you weren't expecting or that anyone that you know might have as well. That's where connecting with peer support, where youth, individuals that also have these diagnoses can also go and connect with others. If we see that after 6 months, these symptoms that might look like anxiety or depression do not go away, that's where we might look at providing a psychiatric diagnosis and possibly looking at medication therapy as well.
Okay, thank you. Um, and are there resources or, strategies you would recommend for providers to share with caregivers to help support them? Because as you mentioned, there's a lot of stress, maybe feelings of shame or just different feelings when they first get that initial diagnosis. And, what do you recommend for parents in terms of their support?
Connecting with a peer group. There are asking your medical provider about peer organizations that allow parents and families to connect with others. to help normalize those feelings, as well as to help with feeling isolated. Um, but asking for a medical provider for a referral to a behavioral health specialist, such as myself, our team, um, a social worker, as well as a psychologist that has um, experience in working with individuals or their caregivers that have these diagnoses. That's what I'm doing. So all of the strategies that I discussed today are very, very valuable and will apply. But peer support is one that I did not mention in my presentation today. And so going back to your medical provider and asking for um, organizations that have peer support can be very valuable.
Okay, thank you. And one of the concepts you talked about was the shared decision making with families. What
Yeah,
are the examples of how you incorporate, shared decision making into your clinical work
yeah.
with families?
Um, after families have met with multiple medical specialties, they've gotten very many questions asked of them. They've been told different treatment plans, what we're going to do first, what we're going to start with medication wise, what we hope to see, the different labs. Um, Whenever they come and meet with me, the first thing I start to ask them are, what questions do you have about your medical care? And are you uncertain or confused about any of the things that you were told today? I do that in support of my team because sometimes when someone's had a little bit of extra time to think about all of the information that's been presented to them, it can allow them an opportunity to ask more thoughtful questions that might not have come up in the moment. And so being able to communicate with my medical colleagues about those questions and if they have opportunities for a nurse to reach back out and revisit that, that is something that is very essential to helping them participate in shared decision making. And so I facilitate that with coordination of care with our medical colleagues. If there's no psychologist that's a part of the team or a mental health provider, social worker that's a part of the team, I would highly encourage the family to reach out to the nurse and ask for an opportunity to find out more information or ask additional questions. Um, this way, they can start to develop patterns of having this be a mutual decision-making process, and that there's no time limit to when they can come back, clarify, and ask additional questions.
Okay, thank you. I did get a question, and this is related to the CE.
Mhm.
Um, there was some trouble opening up the document. I will also send this in the follow-up email, but please feel free to reach out to me if you aren't able to open up the CE instructions. So just an aside.
Okay.
Um, let me look. Can you talk a little bit about the types of evidence-based therapies that you find are helpful for patients and families with DSD?
Yes. One therapy, and I'm primarily use a lot of mindfulness-based therapies, and in those, that could be dialectical behavior therapy, or it could be acceptance commitment therapy or ACT. They emphasize values as well as they emphasize acceptance. In mindfulness-based therapies, there really is this acknowledgement that in life, there's always going to be pain. And just like those who receive a diagnosis, this might not have been the life that they wanted for themselves. Um, and so through mindfulness-based approaches, we talk about how we can move from resisting that life has pain and moving more towards acceptance, so that we can decrease emotional suffering. Strategies such as self-awareness of emotions, noticing, labeling, and describing emotional experiences. And then we work on strategies for how to change very intense, extreme emotions like anger, sadness, how to change those quickly. So we might use exercise if we start feeling rage, or anger. And then if we're feeling sad, overwhelmed by tears and crying, we try and use temperature. So we might apply a cold washcloth, that's wet, has wet, cold water that's been on it, applying it to our forehead or around our neck so that we're able to calm down if we're crying and find that we're unable to stop. Cognitive behavior therapy, or CBT, could be a strategy that is familiar, and individuals might have heard of before. Um, Understanding how our emotions or our feelings are influenced by our thoughts that might pop up into our mind, as well as the behaviors that we might do. And those mutually benefit one another. I'm going to scroll back to the journaling, um, where we write letters, to our future child, or if Sally, in her case, was writing a story, to herself and about herself. Those are wonderful examples of being aware of what emotions that you're feeling, noticing what thoughts go through your mind about yourself and about others. And if we find some that we might be able to test the evidence to see if they're true or not, that's an opportunity to really help us move into a more helpful belief and thoughts about ourselves.
Okay, thank you.
Yeah.
Have you found there to be any link with substance use and DSD?
That has not been something I've come across. I'm not saying that it isn't something that isn't there. I know that in children and populations where children experience chronic health conditions, that there could be some that use illicit substances, or maybe their own medication in ways that works prescribed as a way to cope. Um, but in my experience, I have not.
Okay. All right, thank you.
Yeah.
In your talk, you talked about the pediatric healthcare transition. Are there some resources that are helpful for providers in understanding
Yeah.
that transition piece?
Yep. The Got Transition website is a treasure trove of how to facilitate a healthcare tradition or transition, from pediatric to youth. And it comes with helpful strategies that nurses, physicians, our APPs can do to help structure their sessions to enhance that development, as well as for parents. So if parents need to go and move from being overprotective to be more of a supervisor to more consultative, there are strategies such as checklists. There's little quizzes that they could take, to see and help them with those skills.
Okay, thank you for that great resource.
Yeah.
Okay, we still have time for questions, so please don't hesitate to put your question in the Q&A. While we wait, I'll just cover a couple of closing announcements. And if people have more questions, we'll still have time afterwards to cover a few more things. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. Instructions for how to claim credit, I uploaded that into the chat. And I will also be sending that in the follow-up email after the session. Okay, waiting to see if we have any more questions. And thank you, Dr. Richardson, for providing all this wonderful information. It was great to provide, the information about the DSD clinic that you, Dr. Fuller, and Dr. Ramakrishna, have at the University of Iowa Healthcare. That I think it's just wonderful to share this information with everyone across the state. So I appreciate your time. We got a couple comments. Thank you for your time and great information.
Yes. And if there are things that come up later, I think a beautiful thing about these learning series is that it's really helping building a professional network. And that after you find that you have questions or you have a family that could be useful, like I don't quite remember, but I know that there were some presenters at the university that could be really helpful. We serve as connections that can be used as well. I often forget to mention that outside of this presentation, that if there's something that might come up in the future where we can help patients and families or about how you serve others, please reach out. We understand that this wasn't a one and done and that I know everything about what to do next in the future, but if we can help and consult, please reach out to us.
Thank you. Yes, you all are a very wonderful resource. So thank you for sharing that.
Yeah, of course.
Okay, I don't see any other questions, so we'll go ahead and close. I want to thank you, Dr. Richardson, for presenting today on this very important topic, and thank you all for attending this afternoon and for the great questions.
Yes, wonderful discussion.
Yes. Have a great afternoon, everyone.
Thank you.
Thank you.